So may I invite Dr. Ruchika Agarwal? Yeah, please. Are you ready? She is going to speak on curtailing myopia progression. Are we short-sighted in our approach? As we all know, we are getting more and more myopic patients. Okay, over to you, Dr. Ruchika.
A very good morning, everyone. I think it's a privilege to start this inaugural lecture. So I'll be talking about the role of low-dose atropine in myopia. So first of all, we should understand how big is the problem. So as we can see from this graph that from past few days, the graph has shown a steep up course, and it's predicted that by 2050, the present number of 2.5 billion is going to be doubled. So what we can say that there is a tendency of myopia boom, which has been noticed in recent decades because of high incidence and young age of myopia onset. So there are various theories of, so now what we have realized is not it's related to genetic component, but doing some active intervention should be done to delay its progression. So now environmental factors, they are playing more and more role in myopia progression. So we need to act, intervene to do something, not just prescribing the glasses won't be sufficient any longer. So where are the various myopia control interventions we know? So lifestyle modification, as you can see, we need to pull the kids out of the house, and it is recommended at least 2 hours a day of outdoor activities is must. Then there is contact lenses, orthokeratology, in which we overnight use of rigid contact lenses temporarily changes the shape of the cornea. Then we have various spectacles and contact lenses, and plus we have pharmacological intervention, that is atropine, which is the most easiest to incorporate in our practices. So what does they do? They actually slow down the progression. They are not going to correct the disease, but the final refractive number where the child is going to learn is going to be altered. So previously, few other drugs like tropicamide, timolol, pyrazipine have been tried, but they have not been approved, and there is no as such proven role. Now only drug which has been approved is the atropine. What is atropine? It's a long-standing, non-selective muscarinic antagonist, and this drug has been approved. The use of 0.01 atropine is approved by CDSCO and is commercially available in India right now to use. So how does atropine work? It has a multimodality of action. It relaxes accommodation. Then it causes changes in the scleral extracellular matrix. So the scleral thinning and then choroidal thinning is inhibited. So what is the theory that is proposed is that because of the peripheral hyperopic focus on the retina, there are chemical changes going on which leads to the changes in the final axial length or final shape of the eyeball. So atropine has a role there also. So now the question is, are you using low concentration of atropine for myopia control in children, or still you are in dilemma whether to start or is it effective or not? Now if you want to use, what concentration of drops you should start, how long you have to continue for the effect to continue, or should you combine atropine with other optical methods or not? And so first of all, what is the evidence? Should we start using it, or it's like just simple refractive practice is good? So there have been few studies. One of them is ATOM, that is atropine for treatment of childhood myopia, the ATOM-1 study. It was conducted in Singapore. It had 400 children in the age of 6 to 12 years, and it compared the effect of placebo with 1% atropine eye drop at bedtime. So that was a 2 years treatment period, and 1 year was the washout period, during which we compared the 1 year was the washout period. So during the phase 1, we checked about the efficacy and clinical safety of 1% atropine versus placebo over 2 years. In the second phase, we looked for the myopic rebound after cessation of the atropine. So we'll be discussing the results soon. Then there was another study, ATOM-2, which compared the efficacy of low dose atropine. So in the phase 1, we again compared the efficacy of 0.5, 0.10 and 0.01 atropine over 2 years, evaluation of myopic rebound in the second phase, and in the third phase, those still progressing were given 0.01 atropine over 2 years. So what was the result of these studies? It was shown that the ATOM 1 study, atropine 1% showed definite reduction in the progression of myopia, which was measured by changes the axial length and the change in the spherical equivalent of the spherical equivalent refraction. And in ATOM 2, the result was that atropine 0.01% was effective and safe as well in controlling the myopia progression. So to consolidate the results from ATOM 1 and ATOM 2, it was like 0.01 atropine had similar efficacy at 0.1 and 0.5%. Side effects were minimal. Side effects that include photophobia, glare, and decrease near acuity. Negligible, it had negligible effect on accommodation and pupil size. The children didn't need to give, we didn't need to give extra, photochromatic glasses or near addition. During the washout, the main point was that the rebound was minimal. We can give higher concentration of atropine, but the rebound is more with the high concentration of atropine. So overall myopia progression was found to be lowest in 0.01%, lowest in the 0.01% group. Then there was another study which was that is the LAMP study, which was conducted in 2016 to 2017 in Hong Kong. So it compared the other further lower drugs like 0.05, a bit higher, 0.025% and 0.01% to assess that whether they are more effective and they can they be incorporated. So again it had various phases, the treatment phase, then the placebo crossed over with 0.05%, the washout period, and then the phase 4 to determine long-term effect of 0.05% atropine. So the results were that 0.05 atropine appears to work best over 3 years to control axial elongation. 0.025 and 0.01 were similar in first year, but they were more effective, but then they were similar in the second year. In the third year, they were all similar. So talking about the rebound effect, it was clinically insignificant in 0.05% and 0.025 and 0.01% had no rebound effect. So to just create a clear guideline to how to go about, there was a national level expert consent statement which was released in 2021, how to treat. So what are their recommendations? So whom to treat? So the main target age group should be 6 to 12 years of age with a definite history of progression. Progression by progression we means 0.5 diopter over last 6 months and more than 1 diopter in a year. So younger age of onset, parental history of myopia, children over 12 years, if the myopia is still progressing, we can go ahead and treat the children. Very young children, which is to be noted, axial myopia is rare in children under 5 years of age. So, but if you see, then you can. For pre-myopes, there were certain recommendations like lifestyle, environmental modification. If a kid is coming to you, he's in the pre-myopic range, so you have to, especially these are the ones we need to focus about, lifestyle, environment, taking frequent breaks, giving some outdoor activity, ambient lighting while studying or near work. Now, whom not to treat because of atropinic side effect? People with Down syndrome, congenital heart conditions, cerebral palsy and asthma. So what is the best part of atropine? It is easily available, affordable, easy to administer compared to those contact lenses or your spectacles, which are not affordable by every class of patient. So how long to treat? For at least 6 months. If you see it's working, use either for 2 years or up to 15 years of age, which is longer. If a child's myopia increases when we stop atropine, we can still give it a shot for another 1 year. So what to expect? Initially first 6 months myopia might still progress, so we have to continue till 1 year. Follow up after 3 months, you have to call the patient not to see the progression or effect on, just to see if the patient is having any side effects or not. After 6 months is the earliest time to assess. So take home message is, so we start with initial treatment of 0.01% and we check after every 6 months if it's stable or it's progressing. If it's stable, we continue it till 2 years, stop treatment for 1 year. If it's stable, then it's fine. If it's progressing, then we can again restart the treatment and continue till the adolescent. If it's progressing, then we encourage, we have 3 options. We can encourage more outdoor time. We can stepwise increase the concentration to 0.05%, which is nowadays considered more effective, or we can combine other intervention and we can continue till end of adolescent, and then we carefully stopping or tapering. Thank you.
Thank you, Dr. Ruchika, for giving the overall perspective how to use atropine. I myself is using, and I suppose everybody should start using now. It is sideless, side effect is almost not there. But the only thing is that the patients or parents does not do it as a compliance of 100%. So what I advise that keep an alarm of 9 p.m. and put this drop to child by the parents, because usually we believe at 9 p.m. the parents are there and child is not gone for sleep. So that is my take home advice. Thank you.